Good morning. Such a pleasure to be here as an adult rheumatologist, and I'll be discussing JAK inhibitors and dermatomyositis and our experience at Johns Hopkins. Disclosures are from Pfizer for research support. We have to have this copyrighted material slide, but just background, I think everyone knows here that dermatomyositis is quite heterogeneous in its presentation and also in its treatment responsiveness, as we all know. It's not uncommon for adult patients as well to actually fail 2 or more steroid-sparing agents. And listening to the talks in the morning, it sounds like there are very similar steroid-sparing agents that we use even in the adult world. So typically, our first-line steroid-sparing agents are methotrexate, Imuran or azathioprine, and also mycophenolate. Recently, there's been case reports of refractory dermatomyositis responding to JAK inhibitors, and I'm going to go through my story and also our experience and how it all started. The first case that was reported, and we were also observing this in our own myositis clinic, the first case was out of Germany of a 72-year-old female who had dermatomyositis but also had myelofibrosis, which is a hematologic malignancy. And basically, she had been on IVIG and steroids, high doses, and nothing was responding. And when they discovered she had myelofibrosis, they said, why don't we try this JAK inhibitor because she was positive for this mutation. And when they used that, they were successfully able to taper her steroids and also the IVIG, and her strength and skin improved. So this was very exciting because it was published in the New England Journal of Medicine, and for all patients or even scientists, this is very exciting to get published here. And with this case report, they thought maybe it does block the interferon beta signal transducers and the STAT1 pathway that was mentioned previously, and maybe also regulate dendritic cells and T lymphocytes. But there was some controversy about this case because, as we all know, in dermatomyositis, especially in adults, there is a close temporal association with onset of dermatomyositis and a cancer. So in her case, the cancer was treated, and that is why potentially this patient actually responded. So there was a lot of controversy at that time about this case report. So what about Tofacitinib? Because that's Ruxolitinib in Europe, but in Tofacitinib in dermatomyositis, I think this is a testament to really listening to our patients, because this was truly divine intervention, I think. So I actually had a patient who I inherited from somebody else around the same time, and she had failed basically multiple medicines, including methotrexate, azathioprine, IVIG, and I also had given her rituximab. So initially in presentation, she had a lot of muscle involvement, but over time, is really the skin was just recalcitrant or refractory disease. And when I saw her after trying rituximab, she's like, Dr. Paik, what else is there to do? And lo and behold, Pfizer was coming out with this drug, the Tofacitinib, the first JAK inhibitor, and she was also having a lot of inflammatory joint pain. So I was like, look, I can't really help your skin anymore, but let's try this for your joints. So we did, and about 2 to 3 months later, she's sending me pictures and calling me and was like, I can't believe this, my skin is getting better. So this is truly a testament to always listen to your patients, and it's always a partnership, I think, in order to treat your patient. After that, so we wrote this up, and other studies were coming out that Tofacitinib can potentially be an adjunctive treatment or an alternative treatment for skin-predominant disease. So based on our experience, I'm like, okay, I'm gonna help our patients because this is a rare disease, and we wanna use other drugs because these classic drugs are not working in some of our patients. So we sat down with Pfizer and said, look, we want to do this trial. It took a lot of coaxing, but eventually we were able to get them excited about the project. And so our hypothesis at the time was, well, we want to reduce skin involvement and improve muscle strength in patients. At the time with that single patient, it was really just skin involvement. And we also thought that Tofacitinib will inhibit production of key chemokines like CXCL9 and 10. So we completed the study of Tofacitinib in refractory dermatomyositis, an open-label proof-of-concept study of 10 patients. And our inclusion criteria was basically that you had to have refractory dermatomyositis, and that we defined as active disease despite 12 weeks of therapy, of steroid trial, and or failure of response to at least one steroid-sparing agent. And in terms of active disease, we had to make sure that the patient had skin biopsy proven disease with or without muscle weakness. And as you can see here, we were pretty lenient about the extent of skin involvement the patient had. So a CDASI score of 5 is really, really minimal skin. And we really wanted to take a look at the muscle involvement. So muscle was actually scored lower. If they had severe muscle weakness, they could have entered as well. This may be a little bit different from, I think, pediatric patients, but we did do a washout of the patients who were on other steroid-sparing agent just because we wanted to have a pure study. And surprisingly, I guess the drugs were not working for these patients anyways. So when they were off these drugs, they actually didn't have a significant flare. So, I mean, if they did have a significant flare, we would have certainly put them on other agents. But to enter the study, you had to wash out of all these drugs. The maximum prednisone dose that we allowed at the time of entry was 20 milligrams per day, and they had to be stable for 2 weeks. So here's our study design. At the time with Pfizer, they were like, oh, we're coming out with this new long-acting drug, so let's use it. And I was like, sure, why not? Because it's better for compliance for a patient to take it for 1 tablet a day. So as you can see here, instead of using the 5 milligrams twice a day, we actually used 11 milligrams XR once a day. And our primary outcome that we looked at was the IMAX definition of improvement. And you can see here, our primary outcome measurement time point was at week 12. We also really wanted to test this drug to determine, well, yeah, you're on the drug, but can I really taper your prednisone? Because if we could do that, that's also another testament to the drug efficacy. So we actually enforced a forced prednisone taper at 8 weeks and tapered it out. So the results of the study, we had 10 patients enroll, and the patient's mean age was about 45. Most were female, and 9 out of the 10 were Caucasian. 1 was African American. And percentage of patients on prednisone 20 milligrams per day at entry was just 4. The mean CDASI was 28, so even though at entry we allowed very minimal skin involvement, actually these patients had pretty high scores. A score of 14 to 15 or greater means they had moderate to severely active skin disease. And the mean MMT8, unfortunately, we did not recruit severely weak patients. I wish we had. We had about 1 or 2 who were pretty weak, but otherwise they were pretty strong. And that's also supported by the CK being a bit low. So all 10 subjects actually met our primary outcome of interest, and we also used the myositis response criteria, the total improvement score, which was just validated at that time. It was very exciting for us to use. And 50% had moderate improvement, and 50% had minimal improvement. So the median total improvement score was about 40, indicating that at least all the subjects had some moderate improvement. And you can see here almost a linear curve, so to speak, but at baseline, patients were having about a CDASI of 21. And then at week 4, we can see some improvement. By week 8 and week 12, you can see there's a significant improvement in the skin. Here are some pictures. I don't know if it's coming out well, but you can see the patient had significant shawl sign. And here it's very red and irritated and angry. But by week 12, this was all gone. And there was a little bit left in the neck area. And then in the baseline, this is another example of the same patient, and she had a lot of V-neck sign, very irritated. And then by week 12, the patient had a significant improvement in the V-neck sign as well. In terms of muscle involvement, we also did skin biopsies and muscle MRI at baseline and at week 12 at our outcome of interest. And so the muscle, I don't know if you can see this very well, but here at baseline, these muscles are lighting up. These are the T2 stir MRIs. And you can see they're lighting up here and here. But by week 12, it's definitely fainter here, definitely less. And she was stronger at the end. We also looked at some chemokine markers in the blood, and CXCL9 and 10 in the juvenile dermatomyositis literature look like it also correlates with disease activity. Not so much in adults, but I think we do need to look at it further. But in this, we were very interested in it. And so you can see here that at baseline, it was pretty high, but over time, most of our patients had a stark decrease in their chemokine levels. So it's also showing us in the blood there's some decreased inflammation in the blood by this marker. Some of the exploratory endpoints, you're going to hear about myositis autoantibodies next. We wanted to determine, is there a specific autoantibody that is actually overrepresented in these patients who responded? So we did try to recruit different types of autoantibodies, but we take the patients who who can enroll in the study. So 7 patients were TIF1 gamma, and 5 of the 7 were moderate responders. And I think this is also a very good example of that first patient that we used it in. She was TIF1 gamma positive, and so this study was very enriched for these TIF1 gamma positive patients, and they did have a better response. The other patients were MI2 and NXP2, and 2 of them actually had some severe calcinosis as well. Prednisone taper was very interesting for us. Can we taper this off? And only 4 were on steroids at entry, and with that forced prednisone taper, 3 out of the 4 were able to completely taper off all those steroids, which is a huge feat, especially for one patient who was on prednisone 15 to 20 for at least 10 years. So conclusions for this study and our experience with TOFA. It's the first proof of concept clinical trial of a JAK inhibitor in dermatomyositis, in adult dermatomyositis. You heard about the exciting data from the pediatric patients, of 4 patients that Dr. Hannah Kim looked at. So I think it's promising. It demonstrated strong clinical efficacy by this validated myositis response criteria. And we are in talks with Pfizer to potentially do a randomized controlled trial, but it's still in the talks phase. So I'm hoping that we will be able to use this drug in the future and potentially go for FDA indication, but I think that's in God's hands at this point. Thank you very much.